Yeah, okay, great. Okay, so welcome everybody. So this is our weekly case presentation for the NeoFOCUS group. And my name is Ahmad Sherjil. I'm one of the neonatal consultants in Victoria Hospital, Kirkcaldy, and Queen Elizabeth University Hospital, Glasgow. And I will be presenting I'm sharing a case. I hope you find interesting. So the topic I thought was reflective of my feelings here is, as you can see here, should I be working without it? Um, and the reason behind this, more of a feeling rather than topic, is that its focus is so much evidence-based that it feels like the guiding light. So I'm going to crack on with my case here. So this baby boy was born in a peripheral unit at a gestation of 33 plus 4, not too bad on centiles for his weight. And mom in pregnancy had prom since 21 weeks gestation. She had not once but twice grown a GBS on her vaginal swabs. There was severe oligohydramnios. I couldn't get a hand on whether they did lung volumes or not. Um, so mom otherwise received antenatal care, and then eventually at 33 plus 4 or 5, this baby was sectioned. The cord gases had pHs of 7.1 and 7.0 with CO2 close to double figures, high lactate, and base deficit in double figures as well. So a bit of moderate mixed acidosis. So at birth, was breathing, but had poor breathing effort. So they went through the respiratory support as appropriate. However, and continued and tried some PEEP, but in view of the poor breathing, eventually the baby needed to be intubated in less than 30 minutes after birth. So they commenced him in the unit on PTV, tried volume guarantee. Baby probably wasn't impressed, so they took the baby off the volume guarantee and was requiring kind of moderately high pressures to keep saturations up. And the oxygen requirement that was earlier a bit higher came down to 40s and 50s. So they provided surfactant in the usual dose and felt things were improving in terms of saturations, oxygen requirement, blood gases. And here is the X-ray from them that shows decently open lungs, ET in a little bit high, but okay position. And then they did about 8 hours later, they had there was a deterioration in clinical condition. Oxygen requirement more than gradually went up, and in addition to the rest of the management measures, they did a chest X-ray that showed, according to them, bilateral pneumothorax on the right. Wasn't bad enough for them to intervene on the left. That's one of their X-rays there, and I'm guessing that's the needle thoracocentesis done. So, and this was followed by, so you can see the pneumothorax here. Oops, sorry. Pneumothorax on the left side. Right seems okay. I couldn't find any air leak, at least on this X-ray. So, so that it was the left where they intervened and then placed the chest drain, which I think has done a bit of a job here. The mediastinal shift has settled here, and you can see some parenchyma opened up here, and you can also see the UAC, UVC placed in. The trouble they ran in after putting a chest drain in was the fact that there was not much of improvement. Oxygen requirement just kept creeping up, and the FiO2 was as much as it could be. They decided to commence on nitric as well, and then it was hypotension, poor perfusion. That was their main worry, and they tried desperately, bolus after bolus after bolus, commenced the baby on dopamine, and their arterial pressures were all three components. So mean was low, and the two components were low as well. So they trying to fight the situation of the change to adrenaline and dobutamine, and stop dopamine. And after a bit of struggle with stabilizing the baby, which they felt wasn't stable enough because of the low blood pressure, they finally managed to send the baby across to us, where I found this baby on PTV, on the conventional ventilation mode, with 100% oxygen going in, inhaled nitric of 20 ppm. There was a functioning chest drain on the left side, and adrenaline in a dose of 1.5 milligrams per kg a minute, not micrograms, milligrams, and the butamine on 20 micrograms per kg a minute. And they had given one shot of steroid, etracurium, an appropriate dose, morphine and midazolam. Morphine 20 milligram, midazolam was a little bit higher, and the baby was nicely sedated from a muscle relaxation and sedation point of view. The first line antibiotics had good position for arterial and venous umbilical lines, and they probably attempted an echo as well, and felt there were echographic signs of pulmonary hypertension. So I found this baby having arterial gases with a significant metabolic acidosis, lactate in double figures, and bicarb also -10, -9 in double figures. The pH was low because of the metabolic element. The CO2, however, was under control, under 8 kilopascals. Some coagulation derangement, the full blood count that needed attention later on. CRP was in the mid 30s or 40. UNEs were acceptable. The creatinine was just over 100, 113, 14, and hovered along this level. LFT is nothing worth mentioning at this stage. So when I looked at him, he was muscle relaxed fully. He was puffy all over, and this probably added to his appearance of being poorly perfused with a prolonged capillary refill time. There was hardly anything in the bag for urine. The heart rate was in 170s and 180s. Some difference between core and peripheral temperature. The arterial blood pressure, the systolic was in 40s or low 50s when we first saw him. The mean was in the 30s, and then diastolic in 20s. So there was so initial one or two readings weren't terribly low, but they were drifting down as I was watching him. And pre and post ductal saturation difference, they were wondering. So at this stage, when we had him off the transport incubator, he went into our giraffe incubator, and we thought everything was reconnected, and the journey in our unit had started. There was a sudden deterioration, and the baby just died. There was no cardiac activity in the baby anymore, uh, completely off color. So we assessed them. The chest movement was perfectly okay. There was nothing wrong with the ET tube. We got him detached from the ventilator and started bagging him to get more control on observation of the chest movement. But air entry was poor, but the chest was moving, and you could still hear the air entry better in the chest. It wasn't something like a ET tube displaced, and you're hearing breath sounds more, air going in more in the tummy. So the the ET was fine, no cardiac activity, and he was as good as dead. So at that point, uh, um, I went clinical, as well as I applied the crashing neonate protocol from our POCUS experience. And because the machine was not very far, and I was planning to do an sonographic assessment anyway on him. So in that, needless to say that this was every second, every moment was very long at that. Felt like an hour. So I was so I dragged so I placed the probe on, and I'm going to show you this. Sorry, where's water? So, so all of this was happening very spontaneously. We were bagging him at the same time. We were assessing him for what the chest drain was doing, and I started chest compressions. After chest compressions, I did get the a feeble heart rate back, and by that time there was a very quick probe assessment on his chest. Now, the disadvantage I had was that there was no hockey stick, the microlinear one. So all I had was this 6S cardiology probe. So I placed it on the chest, and you can see on the left side. So this is not the baby. This is somebody else. But I just to make make my colleagues understand what happened, I borrowed from another baby. But the point here is that one, it was very different. It was the wrong probe, not wrong probe, but a very different probe. And yet, the difference between the two sides and what had happened on the affected side was so obvious and so instant that it wasn't difficult for on the if you're looking at the pointer on the left side. This is what I saw: a very dead-looking pleural line, which was moving with the chest as the ventilator or bagging was moving. But I could see that there were no B lines, and the pleural line was very shiny, dead-looking. Whereas in comparison, on the other side, there were lots of B lines and A lines, and I could say, okay, the something wrong has happened with the pneumothorax, the air leak on the left side. So at that time, after a bit of cardiac compressions, had brought the heart rate back, some heart rate back. And when I said, okay, let's detach the chest drain of the suction and use the three-way, a conscientious staff member said, "Oh gosh, okay, I got the valve attached the wrong way." And then we knew what to do with the three-way stopcock. We pulled out about 45 mils of air out, and then placed all the drains in the right manner, baby back on the ventilator. And then with this timely troubleshooting, where I think what I saw with the probe really mattered in saving some really precious moments. Things just went back to the way they were. So I'm not saying he recovered, but he was then as bad as I received him earlier, and very much alive. So the observations and examination was as before. Blood gas, we didn't get a bad gas on him, and there was no rush to repeat it. Chest X-ray, we did repeat it later, which didn't seem to have any impact of the incident. And I kept him on PTV, and then my next mission was to look at the oxygen requirement and the nitric that was being given. So this is one of the X-rays that was later done. It wasn't immediately after this, but I'm just showing it to you that when I started to assess him, the detailed assessment after having recovered from this near-death experience thing, the X-ray showed a little bit of consolidation on the right upper zone here, but well expanded, drain in the right place, not dislodged or anything. So ventilation-wise, I kept to those settings of about 26, 27 of PIP and 5 of PEEP, and the CO2 remained under control with this and was never really a problem. It never went beyond 8 kilopascals, and I wasn't chasing I wasn't looking to reduce it any further. The problem was his perfusion. He looked awful. His hypertension got worse and worse. His diastolic was in mid or low teens, and the systolic was in 30s as well, and slipping. And this was a reliable trace from a UAC. So all three components were low with prolonged capillary refill time, no urinary output, and so at this point, the baby, just to remind you, is still on adrenaline of a very high dose that I have rarely even heard of, and the butamine, and with a lot of tachycardia. So I thought I'll do my assessment and then I'll start tweaking things around, and profound hyperperfusion and a slipping mean arterial pressure. So so yes, then nothing grade 1-ish, nothing worth mentioning on the head scan. The ET was in good position here, and the UAC you can see here where the pointer is, um, and by the way you can see the right ventricle playing up here, dilated, not much contraction. UVC, not the best image, but well, those were the circumstances I got in. So it's sitting just into the IVC, but it's fairly away from the eustachian valve. So I'll take you through the segmental sequential analysis here. So our situs is all good, and worth noticing is this thick, dilated inferior vena cava. And so I got a few so it wasn't one challenge I was facing. This wasn't the machine I usually use. So this is a unit where I normally am not. Um, However, this is a GE machine, but some issues with recording a full clip. So they're very short clips, but you can, I think, still see a bit of a globular, full-looking heart, and the baby was perfumed. And have a look at the contraction here, the septum and the right ventricle. And this baby at this point was 26, 27 hours old. And then I did some measurements. That's the mitral, then this the tricuspid, and these are some ratios measured. So what's obvious here is where my pointer is on the flow across the mitral valve, are very low velocities, and have a look at the pattern. The E wave goes almost horizontal to merge into the A wave, and they're very low. They're I think 0.3-ish at best. The A wave here, and this is true on both sides. So the time duration, number 2 pattern, number 3 the velocity. And here you can see it shows a bit of ratio, but basically it probably gives the same message here with the measurements done.
Ahmad, sorry, Ahmad, to interrupt you. We cannot see. Yeah, I think there is a bit of delay for these slides. Now we can see the AE. Yeah.
Okay, so what are you seeing now, Mahmoud?
Yeah, we can see the Doppler now.
Okay, great. And you have seen the cardiac activity in the previous slide?
That's right.
Okay, great. So this one, I'll very quickly go through this again. This is the flow across the mitral, and you can see one duration pattern and flow velocity, and on the right side as well, the pattern duration and then the flow velocity is low. And under the circumstances, the ratio, I think, gets overshadowed by the fact that I could see poor function on the raw right and left flows across the valves. So these are the tissue velocities. So again, this one where my pointer is, and I hope you're seeing the right slide now, correct one. So what's worth noting here, or what was worth noting for me was, look at the value. They're quite obviously low here. And this is the septal one, and the bottom one is on the it's for the free wall for the mitral valve. And then this is the 5-chamber view where I do it's good to calculate the whole cardiac output value, which I did, but on a busy day, a little trick, I'm not recommending any of this, I'm just saying that's what I sometimes do, is that if you look at the formula for the cardiac output, everything is almost constant, provided you're taking heart rate and the measurement of the aorta at the hinges as a constant, because it's the same patient and you're monitoring it. So the value here was monitoring, or if it's too bad. So here, if you look at the VTI, that's 4.7. That's, and I did it a few times. It was something like this: 4.7, 5.1. And and this comes to about 55, 65 mils per kg a minute of cardiac output, which was really low. Then moving on to the long axis. So a little bit of a quick movement here is only because it's not because of the adrenaline and dobutamine, it's because the clip was recorded just for 2 seconds, so it's just looping itself. So the same message here, the poor ejection fraction shortening, and this is the short axis then, and here you can see the septum and then a big right ventricle here. And again, the contraction, relaxation, they were poor, but this flickering is because of a very short loop. The PDA here, you can see where the pointer is. It's nice and blue and a significant size. And I thought this was probably a better reflection of what I saw. This is a little clip I made from my mobile, because this is a longer duration clip here. And then this is MPA max, so 0.56. So that was the pulmonary flow I was getting. So if you do a VTI here, velocity time integral here as well, so it's as bad as it was on the left side. This is just to show you the arch of aorta, which was in the trouble. Now, from a ventilation point of view, again, I didn't have a problem with the pH in the CO2 and lung inflation. So the issue was to come to some sort of conclusion and assessment of what I had seen clinically, sonographically, and to put it with into the clinical perspective. So after spending some time on echoing, I had a PDA that was very predominantly right to left. I had an abnormal septal motion, tending to be flat or pushed in to the left. The diastolic systolic function, looking at the TVIs, EA waves pattern, were poor. There was very minimal tricuspid regurgitation, and I believe that the reason was the poor RV function. And that is why when things got better, you will see tricuspid regurgitation reappearing or appearing. And the PFO didn't show much of a flow across. I think it wasn't, so I couldn't really record this, but I think it was an equivocal sort of flow there. Or the kind of flow that I couldn't get with an appropriate angle of inclination. So putting this in my clinical understanding, what I understood, I believe, evidence-based, was that remember, this mom had grown GBS twice. She had PROM since 21 weeks of gestation. Plus, there was this oligohydramnios, and we saw the X-ray, which looks a little bit like a bit of a bell shape. So the lungs weren't just smaller; they were also abnormal, with an abnormal vasculature, and I felt GBS was the sepsis driving this pulmonary reason behind the pulmonary hypertension, which in combination with hyperplastic maldeveloped lungs with abnormal vasculature led to the persistence and worsening and severity of the pulmonary hypertension here, and sepsis also leading to a vasodilator shock situation with poor peripheral perfusion and a blood pressure that was low in diastole as well as in systole. And the mean obviously was low and slipping. And also because we were looking at some RV dysfunction and diastolic issues, so I would believe that this all must have compounded poor cardiac perfusion. So which with a consequent biventricular poor function. So what did I do with this understanding, where I had the advantage of monitoring, of tweaking things and then monitoring with my scans. So adrenaline, I needed vasopressors. So adrenaline was at 1.5 milligrams per kg per minute. That was a bit too high, and my lactate was really high in 20s or something. So not 20s, just above 10. So and very persistent. So I started to tweak down adrenaline. Dobutamine, I thought I would go down as well, given the tachycardia and the fact that this is a vasodilator. And so I started to move down on dobutamine and to bring in adrenaline in a sensible dose, and added on noradrenaline here. So with noradrenaline having added, at least the number was getting better. The panic causing slipping of the mean arterial blood pressure, they finally, with that combination, they started to stabilize and probably turning around as well. And we started steroids in 6 hours regularly. I got rid of midazolam, etracurium, and morphine. I felt were good enough because they also have a lot to do with blood pressure. So a bit of tweaking with dose of etracurium, I went down a little bit. Got rid of midazolam, morphine I persisted with. And when I thought at least the number is getting a little bit better, I scanned again and I commenced this baby on 0.5 micrograms per kg a minute of milrinone. And there are a few other things happened. There's a lot that happened, which I would not emphasize on. For a low hemoglobin and coagulation, I did go for some appropriate blood products. But with that puffy baby, I thought it would be appropriate to offer some diuresis when I'm putting so much of volume in, and under the circumstances. So this was the general direction of things I tweaked into, adding milrinone here, and then things started to turn around. The oxygen requirement, that was the first to improve was the blood pressure, and it really showed a very good response within hours. Within hours, it was very obvious that we are going to get a normalish figure with the new adjusted optimized doses. Gases, as the adrenaline infusion started to come down, that whirring adrenaline, which was high and was a matter of confusion, because I didn't know whether this is poor perfusion or it's just the adrenaline, very high adrenaline driving it. So as the adrenaline dose started to come down, that showed a trend which suggested to me that, well, it might be the adrenaline or the perfusion is getting better. The chest X-ray, again, decent inflation. I was never really worried about it, and especially from a VQ mismatch point of view, the thing that I saw, the consolidation patch on the right upper zone, it just did not get any worse. And the ventilator settings remains more or less the same. I did try volume guarantee, but the baby wasn't impressed. So I kept him on a pressure of my choice, and that did work. So there was some urine output as well. And then You can see here, see my gases are looking lovely, 7.3, 7.4, and they're all nice. CO2 very well in control. And that's the PaO2, which is nice and steady. This is the lactate, so that also got under grip, as the adrenaline was still in a high dose, but not as crazy as before. And then this is the the next echo. I did quite a few as required, but that's where I started to seeing improvement before clinical improvement. So much better contraction, much better relaxation. The right ventricle is not as crazy, unbalanced, bigger, and yeah, the septum is still kind of bending itself into the left, but I wasn't expecting a miracle. But this was a sigh of relief to see when the tricuspid regurgitation. Now you can see that it has started to appear, and it was, but it made sense to me that the right ventricle is taking blood in, it's pushing, is able to push against a still high pressures in the pulmonary vasculature. However, the oxygen requirement was down to 70s and 65%. So I had a problem, but definitely heading into the right direction, and I had the evidence on it. And this, you've seen those flows before, and you can see that they look lovely now. They're reaching well beyond 0.5 meters per second, and this horizontal merging of the A wave into the E wave into the A isn't there anymore, and there is enough time here for the E wave to fully express itself. Although it's not, it still wasn't normal, but definitely not the same as before. And here I did these two for, this is the 5-chamber for LVOT, where you can see that if you do a velocity time integral here, which I did, it was twice the one I showed you earlier. So it was 44.7 that I showed you here. It was 11 or something. So the cardiac output clinically was looking better, but here I could see that it almost doubled. And the pulmonary flow here in the MPA is a much better flow velocity visible here. And then look at these, the tissue velocities. So the one where my pointer is, this is the the tricuspid, and you can see the EA primes here up to 15, and the S prime, that they've gone well above 5 here as well, and they're definitely better in for the septal one. And the mitral one, well, this is always a bit skewed, and I always tend to get this. It's more of the angle, but anyway, this is clearly better than the ones we saw earlier. And then we have our lovely PDA here. It's gone very orange, and the flow here, it shows that it's now very predominantly left to right. And this is, I thought this was, so this is the same baby, but this is from on mobile. And so a nice big PDA, but it wasn't the same as before. And the pulmonary veins, I don't think I showed you the flow earlier. They were really poor. Now you can see the whole crab here with both the lower pulmonary veins and the upper blues. And the D wave is above 0.5 here. So this is like the PDA, the left to right PDA now talking. And this was, I think, another yeah, so this was probably the 48 hours age echo, the last one before I left the baby. And here you can see the septum and the right ventricle here, where you can see the flows. It looks nice. And by this time we were weaning down nitric, and yeah, so the oxygen requirements were under 50%, and I was weaning off on all the inotropes as well, and the plan was to keep milrinone going as the last thing. And then well, it's needless to say that it was a very exciting, interesting, and successful weekend with this challenging baby. So I came back to see this child exactly about 8 days later. So when I came in, he was looking good. He was a different person altogether. However, this guy was still had his tube in, and was off his even sedation was almost totally weaned off, and I was happy to see him, but a bit disappointed that he was still there was the tube still in, but everything else, all the observations, everything had normalized. So I learned that just 24, 36 hours ago, extubation was attempted, and that was unsuccessful because the baby had exhausted itself, ran into respiratory distress, and was stressing, and they finally placed a tube in. Didn't like the high flow he was extubated on. So I thought he was ready for extubation, but this time I wanted to make sure that he gets rid of the tube for the rest of his life. So what I did was to do. What I did not do was to do the usual thing: sink or swim policy. Take the tube out on purely clinical basis, and when it sinks, swims fine, sinks, put the tube back in. So I scanned him again. And I don't know whether my colleagues are listening. Do you do a score and write it down? I don't often do this, but I scan and like to see how the parenchyma is looking like. The baby's respiratory drive was all okay. So it's not about just getting a score, low or high. It's about one, the score and the understanding that yes, the parenchyma is good enough for extubation, but also to what respiratory support. Um, so I did a scan on him, lung scan, and so and these scans are this baby's own scans. The previous one with the crashing unit was a panic thing, so I couldn't record much, and it was. But this is his thing. So this is the right side. Now have a look here. Lots of B lines. The RAV3 lateral side, lots of B lines here. This one, where the pointer is, it looks very nicely. So a nice aerated lung, but there is a significant number of B lines here, and the same sort of message on the left side, where obviously the baby has now gotten rid of the chest drain and stuff. So lots of B lines here. So I thought that the reason for unsuccessful extubation could be putting him on high flow. He probably needed a CPAP thing. So with this evidence supporting me, I extubated him onto CPAP. This guy never looked back. He was in high flow in a couple of days, and then he got transferred back. And yes, of course, I did that laryngeal edema prevention steroid. We did one shot of steroid. 4 hours later, we extubated him, and then the second shot 4 hours after extubation, and then another one after the third one next day. And I chose this course because this avoided a delay in extubation. So successful extubation, no problems. And I did a last echo before he was being transferred, and it all looked lovely. I mean, it's structurally the heart was all normal, PDA nearly gone, and should be followed up in the clinic at some point, but it seemed all good. Yeah, so that finishes my case here, and I thought I'll just ask you, everybody's views on how do they manage doing this, the whole protocol thing, because for me it was great. It was quick. Obviously, this was with the thought in my mind, on everybody's mind, that this is a pneumothorax baby, but still. So this is Yasser and his Yasser et al. That's the crashing unit protocol, the CNP. And I think we got to the lung focus there, and we found the pneumothorax gone bad, and the drain was already in. We just took air out, and a massive emergency that could be a potential disaster was avoided. And then the lung score pre-extubation. Yeah, so I would also here request your views. The meta-analysis here that I was looking at says um, not much. I mean, meta-analysis says that the need for doing more studies. And the other one here, the study just suggests this is about premature infants with neonatal respiratory distress. And so this is a premise. Um, yeah, so with this, yes, that's all I wanted to talk about today. And thank you very much for your patient listening.
Thanks, Ahmed. That was an excellent case presentation, quite challenging one. I'm sure we will have many questions. Got Mo's hands up.
Hi, hello. Can you hear me?
Yeah, I can hear.
Hi, Ahmed. Nice presentation, excellent. And I would say I would manage it the same way you did, the same way of trying to get rid of the muscle relaxants and the high dose of sedative that will help you with blood pressure. And also work going with the norepinephrine and the minorenone dose. That also will help your pulmonary hypertension. I think the only thing that I will do differently is just a volume guarantee that I would have done. But from a hemodynamic point of view, I don't think I have done anything different. Now, whether high flow or CPAP is better, it brings us to the question: what is flow and what is pressure? Which is going to be a debate for a very long debate. But otherwise, I think this case was managed beautifully. Thanks.
So thank you, Mo. Yeah, you're right. I think I totally agree with what you said. Yeah, I just feel CPAP is there's a seal. You can in a way know how much pressure is possibly going in. It's a little bit more reliable thing in creating a pressure column from the nose to the vocal cords. And you're right. It's a discussion. But my point here was that this boy probably needed more respiratory support than he was given. That's all. I mean, by lung scanning, I could just let the team know that it's not over yet. Just don't get carried away. It was a failed extubation, so do steroids, do whatever we can do.
Aaron, do you want to comment?
Yeah, sure. The first thing, Ahmed, is what a wonderful presentation. How, it's a fantastic management. I think all the things that we learn, we talk about, I almost saw everything being practiced, and that is what probably made the baby better in no time, really. It was very well managed. A couple of things to start with. I think in the local hospital, one of the X-ray that you initially showed, it showed a straight tube. You did mention about needle thoracocentesis. And I was a bit surprised looking at that X-ray because normally you wouldn't X-ray a baby during needle thoracocentesis. Wasn't sure what that was. A bit surprised about the fact that the baby was already puffy by the time the baby came to you. It sounded like the baby was about 24 hours old. So wonder about how much fluid volume has been given, and particularly in the setting of a high dose adrenaline, which in itself can actually cause myocardial ischemia and dysfunction. It's something to take into account. The other thing, obviously, you had a high lactate and all, and that's probably because of the adrenaline. Now, in one of the echo images that you initially did, um, you did allude to the VTI, which was actually quite low, quite correctly saying that actually the cardiac output was low. But on the same echo clip, the heart rate it was showing was 432. There was no ECG. I couldn't see an ECG. So that must be spurious, I would think. But apart from that, it just looked fantastic and very, very well managed.
So thank you very much, Aaron, for your appreciation. Thank you, really. So yeah, the heart rate was nothing. There was no ECG leads. Yeah, so the real life is a little bit tougher. So I remember trying it, but that 400 heart rate is an artifact. So that is why I just find VTI more in my control. From a reliability point of view, I would get a reliable five chamber view, get my thing, and then monitor from what I do with my own hands rather than a dodgy leads telling me what the heart rate is. I know anybody cardiology sitting here would shoot me for saying ECGs. I'm sure you remember your days. They would be very upset. Training days, they wanted ECG on. But anyway, the VTI, as I mentioned, the rest of the parameters. And the other thing you said, the needle thoracic. I don't know the answer to this. The needle in the chest and why was X-rayed. I think they probably thought should they do a drain in or not. They thought the right was pneumothorax also, so they probably left the cannula in so that they could use it again. I'm theorizing this. I'm not 100% on this, but this was before the baby had it. And what was the third thing you said? The adrenaline doses or something, right?
Yeah, I was just mentioning that the dose of adrenaline was high, which obviously would cause the lactate to go up.
Yes, that's right.
And it has the potential to cause myocardial ischemia and dysfunction on its own. So I think that was a right observation, and trying to bring it down as well would help. Yeah.
Yeah, yes. So you're just taking words out of my mind. That's correct, because then when I saw a slipping down arterial pressure, I didn't. A natural response could have been that okay, we'll keep adrenaline the same and add on something. But no, I brought the adrenaline down to a sensible. I mean, 1.5 mg per kg. But I think again the real word is a bit tough. So people who had the baby, they thought they were losing him, so they went for at least 3 saline boluses that were recorded. Maybe there were more, and I think there were some blood products as well. So yeah, but then they did manage to get the baby to me in one piece, so I think that's fine.
Great. A quick question, Ahmad, and then I will pass to Santosh. I think Mona as well has her hand. So I'm not sure if I missed that during your presentation, but this baby was on 20 of nitric. And obviously, when you did the echo, you could see biventricular dysfunction, including LV dysfunction. So have you attempted to wean the nitric? Because obviously it's not going to help. It's in fact going to make it worse. Or did you keep it going while you're trying to improve the cardiac function? So that's a question. The other thing about assessment for readiness for extubation using the lung ultrasound score, just a comment that this hasn't been evidence-based yet. There are just some trials which was not conclusive. And personally, if you ask my opinion, I don't think using lung ultrasound alone is helpful to assess readiness for extubation because of the cardiopulmonary interaction. So it's not only the lungs, it's the heart interaction as well. So I don't think just using lung ultrasound alone and getting the score, obviously it helps to rule out consolidation, but the score itself, I'm not sure if it is useful, to be honest. Thanks, Ahmed.
Thanks, Ahmad. Yeah, that's absolutely right. The score directly has nothing to do with the decision. So between the two, respiratory drive, lung parenchyma, the lung can only tell you what the parenchyma looks like, whether it's consolidation or But yes, the rest of it, including diaphragmatic excursion, nothing is conclusive at all. This was more about giving me an insight into the lung parenchyma, and that's why I brought this as a question for my colleagues. So I totally agree. It's not, and I think the meta-analysis that I showed here, it just concludes more studies required. Yeah, and the other thing, yeah, the nitric. I couldn't. I thought under those circumstances, I couldn't take any chances from a team confidence point of view. So I convinced them that that if we target the cardiac function, things will change, and they did. And after that, I was very quickly able to get it down to 15 and all that. But before that, I knew what I was doing. But then, there's no point if the team is not behind you and with you. So yeah, that's what happened.
Thanks, Ahmed. Santosh, and then Aaron.
Thank you, Ahmad. And Ahmad, thank you so much for a wonderful case presentation and your management as well. I think I really appreciated, I think, your echocardiogram and altering those inotrope combinations, I think was crucial to this success story. I think just one comment, I think, the heart rate that we got, that 400, actually, what I could see on that echo was probably, I think you were just taking that systolic time, not the whole cardiac cycle. So probably that might be the reason. I think it was showing 438. Had it been a full cycle, I think it would have been dropped down to 200 or something. So that was, I think, what I saw on that clip. But I think apart from that, I think probably, and the other thing what I find is, I think during that cardiac arrest, when you did that, because I think you're going with the cardiac compressions and everything. How did you manage to do a quick echo or the ultrasound as well at that time? Probably at that stage, I think probably you would be focusing right on the compressions and all those stuff. But I think it was a great effort, I think, and with a very positive outcome. So that was nice. And the other comment, I think, what Mo said about, I think, use of nitric. I think even before your first echo was done, I think this baby was already on nitric, and with
Yes.
that myocardial dysfunction, was it the right step or not? I think that is something to think of. But I think well done on such a wonderful management and that outcome, really. Thank you.
Thank you, Santosh. So I did not do any echoes or any scans when the baby was in cardiac arrest. I did not. So it was all clinical. I saw what happened. We got him off the ventilator. I said, get everything disengaged from the machines in the wall. So we disconnected even the chest drain and started bagging him. Because my plan was to scan him at some point, so by chance things were ready. So after I heard I could hear it was a bliss. It was such the loveliest sound that you would hear that the heartbeat, the cardiac activity came back. Then I barely managed to do anything else. It was just that the same 6S probe on the chest, and like within few moments, I knew what was happening. That's it. That was in and out. So the entire crashing neonate protocol that I brought in, this is an academic thingy because at the end of the clinical case presentation, you do some discussion. So none of the abdominal scan, head scan, nothing of that sort happened. It was just, and to the extent that I didn't, at the recordings I showed, there was some other baby with a pneumothorax with 6S probe that I used to use for pneumothorax a long time ago. I couldn't even record anything. I just went in and out. I got my decision. That's it.
Thank you. That's great. Thank you.
Okay, Aaron, is that another question?
Yeah, just a quick one. I was actually going to say what Santosh has just said, and then I thought I may sound very dumb if I ask, how did you manage to do a point of care ultrasound while doing the resuscitation with the CPR? But I've got the answer now. But it definitely provided you with a very sort of clear answer. The other thing, I'm not sure how obviously the operational delivery network around you works. We strongly discourage the use of dopamine, particularly in the setting of suspected pulmonary hypertension, particularly if a baby started on nitric. It sounded as if the dopamine was started and the nitric was started. Obviously, because the dopamine obviously can cause increase in the pulmonary vascular resistance and worsen the pulmonary hypertension. Just as a point, within your ODN, do you practice, being in tertiary care, do you practice having a unified guideline? Because that is what we have done in the whole of the Northwest. And the other small comment, obviously, is adrenaline. While it's a good medication to actually help with the cardiac output, obviously in higher doses would also increase the pulmonary vascular resistance in addition to the systemic vascular resistance. Those were the two sort of comments more than anything else. Thank you.
Thanks, Arun. Yeah, so all I'm going to say is they're valuable, good, great comments. Yeah, so yeah, you're right.
Thanks, Arun. Mona?
Oh, sorry. Thank you very much. It's a very interesting and fantastic presentation. I have just one comment and another question to Santosh, actually. The comment is how to calculate the heart rate if you don't have an ECG on. Actually, on the GE machine, you can do it, and I think also in Philips. So if you can calculate it by, and the GE, you go to, if you are on in the still image of the VTI, you go up on the generic, on the right-hand side, on the generic item or generic side note under the specific measurements, you can find heart rate, and you measure from the beginning of the first of the envelope to the first of the second, of the first part or the beginning of the following beat. So with this, you will get more or less okay heart rate you can use to calculate the cardiac output. The question actually, Tushad, how did you manage to get the whole network to stop using dopamine? Because here in West Midlands, we've written guidelines about the pathophysiology management of all hemodynamic compromise, and it's still in the process of being published. But we've done quite few sessions on teaching the teams here, but still people use the first line is dopamine and butamine regardless what is the pathology. What did you do to change the whole region or the ODN practice?
Thank you, Mona.
Actually, I was asking Santosh.
Yeah.
Sorry, Ahmad. I'm not interrupting you.
No, that's fine. Santosh, are you there?
Yeah, I'm here. Mona, I think I just made a comment about, I think the heart rate, what was the 400 was purely because I think the cursors were just measuring the systolic length rather than the whole cardiac cycle. I think that would have given the right answer for your exact heart rate also. So that was my comment, but that I think otherwise, I think it's, yeah, that's about the heart rate. The inotrope combination, actually, I think Arun has already alluded to, I think the use of dopamine and the role in causing increased pulmonary pressures as well. And I think most of the time, I think when it's a pulmonary hypertension, I think the inotrope of choice when you are really pushed to do, I think we feel that I think we prefer a combination of a noradrenaline with a bit of a dobutamine if that helps, or otherwise just noradrenaline on its own. Adrenaline, I think, is probably preferred more on a PICU settings. I think they prefer more adrenaline, but I think we tend to avoid it purely because of the complications of high lactate and tachycardia and all the stuff. And I think if you've got a good cardiac function, then sometimes I think milrinone is much more helpful. So that is just a bit of a rough overview rather than anything else, Mona.
I think my question was, how did you make the team follow the new guideline? Because we have the same guideline. We are with our guideline trying not to use dopamine in cases of pulmonary hypertension. Now, most of the pathophysiology-based guideline we developed doesn't have dopamine, but to make people follow this, what did you do? This was my question, actually.
All right. Okay. I think in my unit, I'm a bit lucky that most of my colleagues are able to do some echo and then make a bit of a rational decision. And if that is not available, also, I think some of us will come and then help trying to alter the combination of inotropes. And I think it is just a question of now, probably this is a time I think people are thinking more on hemodynamics and what is rational, isn't it? That is the question which we were not asking ourselves before. And so probably that is a bit of a shift in culture that is probably quite evident in most neonatal units nowadays.
Yeah, and if I may add to that, Santosh, we had a guideline for management of hypoxic respiratory failure, which we did in Scotland a few years ago. And we tried to bring everyone together because that's a challenge. You can write whatever guideline you want, but who is going to buy it? If they're not engaged, then there is no point. So that was the mission. We did lots of education, skills workshops, invited colleagues. We did through the Scottish Perinatal Network webinars and grand rounds, presented cases, explained that we need to shift away from regimented management protocol to pathophysiology-based protocol.
Yeah,
that's the whole idea, because you can give dopamine, dobutamine as you wish, but the baby is not going to make it because we're simply making things worse, making worse tachycardia, less time filling for the heart cardiac cycle. But also you're increasing oxygen consumption on the myocardial level. So, and adrenaline and dopamine in particular are very bad for pulmonary vascular resistance. So if you're treating pulmonary hypertension with dopamine, you're actually making things worse. So that was the message, our colleague, and they started to be engaged. I think you just need to do lots of education.
Yeah, I think the problem is people will say, oh, we've been using dopamine for years and nothing happened. So what is your evidence? What is your evidence right now on this will improve the outcome? And unfortunately, because it's a consensus-based management, there is no clear evidence, and we haven't got any RCT which address this. But the experts have been using this, and they showed us when on observational studies that this improves the outcome. But it is you're right. It's cultural shift and change of the mindset of the people. But I have found it very difficult in my situation.
Yeah,
thank you.
The problem with RCTs and evidence is it's really difficult for sick neonates to randomize babies on different inotropic support. And they've been using it, yes, for years, but I'm sure many babies died without knowing why they died. But when you look back, probably they died because of the not understanding the pathophysiology. It's just a cultural change and shift in management. It just will take time, I suppose.
Yeah, if I'm allowed to add one more line, Mohammed, I think the same thing is with the use of 100% oxygen and nitric. Even if there is a cardiac dysfunction, if you say also that I think nitric is not helping, let us try and stop. But people have got that, oh, baby is 100% oxygen, we need to do something. So I think that is also will change over time. But again, I think probably we have seen that also quite often. So yeah, thank you.
Thank you, guys. Thank you.
Aaron, you wanted to come in?
Yeah, just quickly, a couple of things I wanted to answer. First of all, there is some evidence. There is definitely evidence on the horizon. There is a paper which has been published by Afif, published on Archives in 2024, where clearly he talks about how to manage hypertension. This is obviously about the preterm infants. And there is retrospective studies done as a comparison between dopamine and noradrenaline. And noradrenaline has been found to be better than dopamine. And also, there are quite a bit of evidence which is around. I think it will be worth digging this paper out. It's very easy if you just type in Afif and Mulali is the paper authors. Mulali is the first author, I think. And it's actually been shown that dopamine exhibits many extracardiac effects, including impaired central cerebral autoregulation, pituitary suppression, and also the higher doses are associated with arrhythmias. And recent data also suggests that it's associated with increased mortality, neurological injury, morbidity, including NEC. And there is also evidence in the children, pediatric population, that dopamine is actually quite harmful. And 25% of the dopamine is converted to norepinephrine. So I think there's considerable amount of evidence which is out there in the recent papers, number one. In terms of the operation delivery network, the way we worked out was we have obviously our own ODN for the whole of the Northwest. There are 5 tertiary care hospitals. What has actually happened is that we've liaised between all the tertiary centers. We've actually got their guidelines, and we had a uniform platform to discuss about changing the guidelines and keep it unified within the whole of the Northwest. And we've been able to do that, discussing the hypertension guideline, and that's how we've come to a sort of consensus on how we're going to manage. I hope this answers most of the questions Mona had.
Yeah, thank you. Actually, yes, I read the Afif's article. Unfortunately, it's a review article. It doesn't have strong evidence. And even you said, yes, there are observational studies, but observational studies are not strong evidence. They prove only association, they don't prove causation. I totally agree. I agree with you that I have hemodynamic interest and I'm passionate about it, and I want everybody to be using the best drugs for the best condition. Yeah, but it's a culture. I think it's culture, and they struggle within the team and within the region. But I think it needs time. And hopefully before I retire.
So that's why, Mona, if you want to share the flyer for this workshop, hopefully we'll talk about that in more details. Try to, that it's all about education and just raising awareness about what to use and the principle and concept of pathophysiology-based rather than, protocolized management. Hopefully that will get people to buy in more.
Yeah. I do you know, Mahmoud, I did how many sessions of that? I think 4 or 5 sessions, and recently one a couple of days ago on hemodynamic management of different conditions, hoping that the practice will change. But yeah,
don't give up,
it's not
Mona.
easy.
Keep going, and I'm hopeful that through our group as well with BAPAM we'll do more webinars, so more people will attend as well. So good stuff, great stuff.
Yeah, great. Thank you. Actually enjoying the discussion.
Mahmoud, if I comment, actually one of our, I'm sorry, Ahmad, I couldn't attend most of your case, but what I gathered from the discussion, what was very, very interesting. But I think so what the Mona point is very, very valid is in terms of we all attending this meeting is all convert, and there's no point teaching the converts. It is the non-believers, we need to get the message across. And Mona, one of our biggest mission of this NeoFOCUS group, which it was a long journey for us, is to come with this uniform consensus and framework of practice. And one of the things which Mahmoud as the chair is driving is probably, we might not have evidence for everything, but what we can have is the best practices, which we are practicing in terms of various places. So we come with a consensus statement or a framework of practice. And one of them, our aim would be to have a framework of practice for management of PPHN, hypertension, and we have a committee of people who are looking into it. So, so there is, a drive and a need for it.
Yeah,
yes,
thank you.
Yes, absolutely. And watch the space for more to come, hopefully soon.
And as Mahmoud has mentioned, just to bring to your attention, is please use this opportunity and do the booking very quickly, because the spaces are very limited. And we are not even advertised and published it anywhere, and only in our group, and it's already have significant amount of registration last 24 hours. So please, for interested people, we want our NeoFOCUS people to be there. Please do your booking as early as possible.
Great, thanks everyone. Thanks, Ahmed, for the amazing case. Excellent, well done. And we'll see you next week.
Thank you. Bye.
Thank you.
Thank you very much. Bye-bye. Bye-bye, everyone.
Bye.